So where are we going with this study, and when do you think it's going to be in the clinical armamentarium and available to people for the clinical use?
Yeah, so actually, what you mentioned right at the beginning there was biopsies, and our study is the first step. We don't want to run before we can walk,
Right.
And I'm a scientist, and we're all quite cautious with what we report, and we'd love to roll this out in the clinic, but that's not going to happen next week. We still need to do, like you mentioned, it's quite a small study. We need to do this on a larger number of patients, and if you're happy to collaborate, we're happy to work with you.
Yes, of course.
But in the first instance, so because these results are based on radical prostatectomy tissue, so that's the entire prostate has been removed, and now we've got a predictor on relapse following surgery. We really want to check how well these will work on biopsy material, because, if we can predict on biopsy, maybe we can have men, Gleason 7, avoiding surgery altogether.
That would be tremendous.
Which would be ideal. So that's the very next logical step. Does the signature translate to biopsies? The only thing, it's come down to the technical work as well. Can we get enough material, actual DNA, out of those biopsies to do the same analysis? To
validate your study. That makes a lot of sense. Absolutely. So
exactly.
Once you have a report, you always want to know if it's because of chance or if it's real. And that's why Dr. Adams is going to do more study on some of these biopsies, which I don't think you're going to have any shortage of that in UK. But it's a fascinating study. Obviously this is my field. I do a lot of robotic surgery for prostate cancer. And I also lived in London for about 3 years. So we're here. Please feel free to get in touch with me, and we're happy to collaborate. And I appreciate you being with us today.
No, thank you. I've got a last point. We've actually got tissue microarrays for each of these patients as well, each of our men, all 259. So they've all had their tissues put on tissue microarrays that are ready, and we're offering that as a collaborative resource as well to test biomarkers, because of course, it's all well and good doing things on a molecular level, getting DNA and RNA, but actually often we use antibody staining, and the pathologist who's already got that material. So we're offering that as a collaborative resource for people who are interested in carrying on this work,
I think this field will continue, and you're never going to retire, because just the concept of, like, for example, I can come up with so many topics. How does diet affect what you're going to find on those biomarkers and genetic component? People who have, like, for example, have a diet full of fatty food, they don't exercise, sedentary lifestyle, does it really make any difference on their genetic components, or anything changes at the level of DNA or RNA? So these are things that, we can continue to study, and it's fascinating because for years, it was always elevated PSA meant biopsy, and biopsy meant radiation or surgery, and that was a very naive way of thinking. And now with our images and MRI studies and genetic components, etc., we can help. So if there are any people out there who have questions about prostate cancer and these genetic tests, we're going to post a lot of information on our social media and on prostatecancer911.com. We have Dr. Adams from UK Cambridge Cancer Institute, and I really thank you for your input, and I'll be in touch with you. Please send me your information, and we look forward to having great collaboration again.
I will do. Thank you very much for having me.
Thank you so much.